Mark your calendars for RSNA 2024, Building Intelligent Connections. Join us in Chicago for the biggest week in radiology from December 1st through the 5th as we explore how to intentionally and intelligently build the right connections between people and technology, expand your network, elevate your skills, and navigate the changes shaping medical imaging. Registration opens July 17th. Go to rsna.org/annual meeting. Welcome to the RSNA RadioGraphics podcast. I'm your host, Dr. Jonathan Revels from New York University. On today's podcast, we're going to be venturing into the epicardial space and discussing Dr. Rosé Altaldil and colleagues' article on the topic that came out in April of 2024. Now, nestled between the myocardium and the pericardium is the epicardial space, and this might seem inconspicuous and maybe overlooked, but it plays a pivotal role in cardiac health, and that's why this article is so great. It covers so many topics ranging from the physiologic role of epicardial fat to the tumors and tumor-like conditions that can affect it. So the epicardial space is an anatomic region that's located in betwixt the myocardium and the pericardium. It's bounded internally by the subepicardial myocardium and externally by the visceral pericardium. The epicardial space includes two different components. The first layer of the pericardium, which is intimately related to the heart and considered part of it, and the epicardial fat, a visceral adipose tissue that covers the myocardium. Now, I want to clear up some terminology that I think we all get confused about from time to time, and that's the term epicardial fat. So the adipose tissue that resides outside the fibrous pericardium is termed the pericardial fat and mediastinal fat, but sometimes this is called the epipericardial fat, and that misnomer makes things confusing. Now, the fat that's residing within the epicardial space, meaning between the myocardium and the visceral pericardium, this is epicardial fat. And the epicardial fat is not merely a space filler. It houses critical structures like coronary arteries, veins, lymphatics, and nerve fibers, all of which can contribute to some of the pathologies we're going to be discussing in a minute. The clinical significance of epicardial fat extends beyond its anatomic role. The different biochemical, molecular, and vascular properties of it differ from those of fat located outside the pericardium, and recent studies have highlighted its involvement in metabolic activities that can influence cardiac diseases. For instance, epicardial fat can have negative effects on the coronary arteries and has been linked to the development of coronary artery atherosclerosis. And a large volume of epicardial fat around the left atrium has even been associated with atrial fibrillation. It's because of these associations that epicardial fat quantification may one day become a useful predictor of cardiovascular disease. When it comes to pathologies in the epicardial space, we can broadly categorize them into neoplastic and non-neoplastic conditions. Neoplastic diseases can range from benign entities like lipomas to malignant entities like angiosarcomas or metastases. Non-neoplastic entities include things like inflammatory or infectious diagnoses, as well as other things like coronary artery abnormalities, such as aneurysms and fistulas. Unfortunately, I don't have the time today to cover all the excellent diagnoses that were discussed in this article, nor can I dive into every imaging assessment beyond CT and MRI. However, the authors have done a phenomenal job organizing the various pathologies and imaging modalities for you, and they've included some truly impressive images in tables. So I highly recommend you all check out the full article when you have the opportunity. Now let's get into some epicardial space pathologies. First up are the neoplastic lesions. So, epicardial space lipomas, while rare in general, are actually the most common benign epicardial neoplasm. These slow-growing tumors are commonly found incidentally, but they can exert mass effect on the cardiac chambers and even the coronary arteries, which may be why some publications have described them as leading to chest pain. Now, on CT and MRI, epicardial lipomas will look similar to fat elsewhere, and they most commonly reside near the left atrium and left ventricle free wall. MR may demonstrate a thin peripheral capsule, but that's not always the case. When you see internal septae, enhancing components, or infiltrative features, you need to raise concern for a possible lipoblastoma or a liposarcoma. Now let's talk about paragangliomas. Just like paragangliomas elsewhere, These neuroendocrine tumors can produce catecholamines, leading to hypertension, and they can even exert mass effect on the adjacent cardiac structures. The most common epicardial space location for a paraganglioma is going to be near the left atrium or the root of the great vessels, especially the aorta. Now, given the hypervascular nature of these tumors, they will avidly enhance on CT and MRI. And on MRI T2 weighted images, they can sometimes have the classic salt and pepper appearance due to flow voids and hemoglobin degradation. Preoperative coronary angiography is advisable in paragangliomas before they are resected because they are directly supplied by epicardial coronary arteries. Now let's talk about some malignancies. Metastases are going to be the most common malignant epicardial tumor, and they should be considered first when you find nonspecific epicardial lesions in a patient with a history of cancer. Now, about a third of cardiac metastases are actually located in the epicardial space, and this usually occurs via lymphatic spread. And what happens in this instance is the Mets get to the mediastinal lymph nodes, and that leads to slow or static lymphatic circulation, which in turn allows for retrograde dissemination of the tumor cells. Now, although lung and breast cancer are going to be the most common malignancies leading to epicardial metastases, many other cancers can do this as well, such as melanoma. On imaging, you may see multiple epicardial masses, and on MRI, the metastases can be T1 hypo or iso-intense to myocardium and T2 hyper-intense. You may also find pericardial thickening, a pericardial effusion, and other features of metastatic disease within the imaged field of view. Our next epicardial space malignancy is angiosarcoma, which is a highly aggressive tumor that commonly has metastatic disease elsewhere at the time of diagnosis. It has a characteristic location along the right atrioventricular groove, and it can manifest with intracavitary growth into the right heart chambers. Now, because angiosarcomas are hemorrhagic in nature, pulmonary metastases can exhibit a halo sign on CT, and on MRI, the mass can appear ISO to hyperintense on non contrast T1 images. When intravenous contrast is administered in angiosarcoma cases, these tumors avidly enhance due to their vascular nature, which can have variable appearances, including patchy, rim, or centripetal. The last malignancy we'll discuss is cardiac lymphoma, which more commonly results from secondary involvement as opposed to primary cardiac lymphoma. Because these tumors grow through the lymphatic network within the epicardial fat, which has a direct relationship with the cardiac conduction system, patients may present with arrhythmias and even syncope. On imaging, epicardial space lymphoma appears as an infiltrative soft tissue with a predilection for the atrioventricular grooves and the base of the heart. Characteristically, it's going to be encasing the coronary arteries and aortic root, but not occluding them. On CT, the epicardial space lymphomas can show up as masses that are similar or slightly less dense than the heart muscle. And when intravenous contrast is given, the lymphomatous tissue can have heterogeneous enhancement. Now, other common features that may be encountered on CT include pericardial thickening, and effusion, and mediastinal lymphadenopathy. Now, on MRI, lymphomatous tissue can have a variable appearance. It may be ISO to hypointense on T1 images and ISO to mildly hyperintense on T2 weighted images. When contrast is given, the lymphomatous tissue can appear heterogeneous or homogeneous. Now let's shift to non-neoplastic epicardial space lesions. Specifically, we're going to talk about IgG4 related disease, Erdheim-Chester disease, and then lipomatosis. IgG4 related diseases are inflammatory disorders consisting of IgG4 positive plasma cells and lymphocyte infiltration that can go on to develop fibrosclerotic tissue and tumefactive lesions in multiple organs and organ systems. Now, in general, IgG4 related cardiovascular disease is not rare, and it most commonly involves infrarenal abdominal aortic regions. The infiltrative soft tissue can extend to the thoracic aorta and the epicardial aortic root. The aortic adventitia can become severely thickened with or without luminal dilation and aneurysmal formation. Coronary artery involvement is less frequent in this condition, but when it is present, it can appear like tumor like soft tissue encasing the arteries, creating a pigs in a blanket sign. The coronary artery lumen can then become stenotic or aneurysmal, and in the latter case, internal thrombi can form within the aneurysms. That potentially may lead to myocardial ischemia. On CT and MRI, you can have periaortic and coronary artery soft tissue thickening, pericardial thickening, and potentially a pericardial effusion. Coronary artery CTA can evaluate for stenoses and aneurysms, and cardiac MRI can add value by assessing for complications such as myocardial infarction and pericardial constriction. Now, moving on to Erdheim-Chester disease, this is a rare, multi-system, non-Langerhans cell histiocytosis that is characterized by xanthogranulomatous tissue infiltration that leads to fibrosis. Erdheim-Chester most commonly involves the skeletal system, but about 50% of patients present with extra osseous involvement that can include the central nervous system, the orbits, kidneys, lungs, and obviously the cardiovascular system. Cardiovascular symptoms are not common when patients present, but over the course of the disease, they usually appear and can range from arrhythmias to fulminant heart failure. And unfortunately, cardiac involvement is considered a poor prognostic indicator. When Erdheim-Chester disease involves the epicardial space, it is typically seen with soft tissue encasing the right coronary artery in the right atrioventricular groove. Now, unlike IgG4 coronary disease, Erdheim-Chester does not usually cause stenoses or aneurysms. You can have tumor-like features that can involve the right posterior atrial wall and extend into the right atrium. The pericardium is commonly involved as well, resulting in diffuse thickening and variable size pericardial effusions that could potentially lead to tamponade. Now, on CT and MRI, you'll see soft tissue and pericardial features similar to those that I just mentioned. And on MRI, the signal features of the tissue can be T1 hypointense, but with avid enhancement, and slightly hyperintense signal on T2 weighted images. Now, if these features of Erdheim-Chester are giving you a sense of deja vu, you're not crazy. The disease has overlap with other pathologies we've discussed so far. For instance, both Erdheim-Chester and IgG4 related diseases are multi system disorders that can affect the epicardial space. Erdheim-Chester typically has symmetric long bone involvement with osteosclerotic lesions, whereas IgG4 related diseases can manifest with chronic pancreatitis and sclerosing cholangitis. Both Erdheim-Chester and IgG4 related disease usually involve the retroperitoneum, with infiltrative soft tissue surrounding the abdominal aorta. However, in IgG4 related disease, this infiltration extends to the iliac arteries, and in Erdheim-Chester, it involves not only the periaortic space, but also the perirenal fat. When it comes to the epicardial space, though, both Erdheim-Chester and IgG4 related disease can involve the coronary arteries. And unfortunately, this does have overlap with angiosarcoma and lymphoma. So, a detailed assessment for multisystemic involvement and multimodality imaging is going to be necessary to help narrow the differential. And ultimately, histologic confirmation may be necessary. The last non neoplastic pathology I want to talk about is epicardial lipomatosis, also called epicardial adipose tissue hypertrophy, which is when there is excessive fat deposited in the epicardial space. While the exact cause has yet to be elucidated, advanced age and obesity could be risk factors. Although the relationship between increased volumes of epicardial fat with coronary artery disease and atrial fibrillation has been clearly established, whether epicardial lipomatosis may lead to an impairment of the right or left ventricle function remains controversial. Epicardial lipomatosis can appear as a mass on echocardiography, and when CT or MRI follow up is performed, a normal distribution of epicardial fat will be demonstrated. Unfortunately, there is no definitive value that has been established for epicardial fat thickness on CT or MRI. So, what are the key things I want you all to take away today? Well, first, the epicardial space is clearly an important anatomic region, and it can have a wide range of pathologies. By understanding the patient history, the lesion location, and the overall imaging findings, you can help narrow your differential. But unfortunately, in some cases, there can be overlap and tissue sampling may ultimately be needed. I just want to thank the authors for putting together an excellent review article on the epicardial space. And again, I encourage you all to take the time and check it out and see some amazing cases and learn about some really great pathologies. Thank you all for tuning in, and I hope you really enjoyed this summary on epicardial space pathologies.